First of all, let me thank the NIC organizers for the opportunity given. Well, I was wondering what exactly is this delving deep in calcified lesions. I checked the Google and found out that it's excavating. You need to excavate the calcium before you start stenting. So primarily it just says that you need to have a significant amount of volume reduction of the calcified segment and then break the calcium with balloon-based strategy. So probably that's what was meant by the organizers. Well, I'll start with the case history of a 78-year-old gentleman who presented with an infusional myocardial infarction to a nearby hospital. They attempted to dilate the lesion. They were not able to dilate it. However, they could achieve TIMI 3 flow with a 1 millimeter balloon, and he was referred to us. We kept him on tirofiban for the next 12 hours, took him up for a procedure. We saw that there was TIMI 3 flow, there was no significant amount of calcification, no significant amount of thrombus, there was a huge amount of calcification there in the right coronary artery. So how do we manage this heavily calcified right coronary artery? We need to think about two options. One, we need to have a significant volume reduction. That's, you need to excavate the calcium, you need to go deep into the vessel with the help of an ablation strategy, and you need to crack the calcium. Deeper calcium needs to be cracked with a balloon-based strategy. Now I'll be dwelling on ablation strategies, that is excavating the calcium primarily based on three techniques. That's you could use an rotablator, you could use an orbital atherectomy, and even a laser would be helpful in certain situations. Also, that's how it would look like when you have significant amount of calcification. You need to use a rota, orbital, or a laser, ablate some amount of calcium, excavate some amount of calcium, reduce the volume of calcium, then go ahead with cracking with the balloon-based strategy, and then deploy a stent. So these are the three options that we have: the rotational atherectomy, the orbital atherectomy, and the excimer laser. In this particular patient, we started off with a 1.5 millimeter burr. We went up to 180,000, and at 200,000, we were able to go across the lesion. Once we are done with the rotablation with 1.5 millimeter burr, we did an OCT run because initially we were not able to get the OCT catheter across. So following rotablation, we did an OCT run. You could see that there is a significant amount of superficial calcium, thin sheet of calcium could be made out. In this image, you could see that at the green arrow, it points to a thick amount of calcium. The wire bias, the rotablator is close to the calcium. The calcium has been shaved off at that particular area. In the next two images, you could see that the green arrow indicates that there is a nodular protrusion and there is a significant amount of protrusion of calcium, that is eruptive calcium into the lumen also. So we understood that the initial 1.5 millimeter burr hasn't done much for this particular lesion. There is significant amount of calcium remaining there. We need to do some more excavation. So we decided on a 2 millimeter burr at 160,000 RPM. We were able to get across the lesion, and that was the rotablation with 2 millimeter burr. And now you could see that the repeat OCT, you could see that in the first image, you could see that there is some amount of shaving off of that particular calcium with a 1.5 millimeter burr, which is better with a 2 millimeter burr. And secondly, here you could see that the burr didn't do much at this particular area with a 1.5 millimeter burr. Here you could see that with a 2 millimeter burr, there is some more excavation being done. And wherein you have in the last image, the wire bias, you could see that significant amount of excavation or volume reduction has been done with the burring. Then we went ahead with dilatation, stent implantation. That was OCT run, which was done again. After that, you could see that there was significant amount of malposition, some amount of under expansions. So, and this particular area at 9 o'clock position, you could see a small amount of nodule protruding on either sides of the nodule. You can see that the stent is not well opposed. So we finally decided that, but again, you could see in this image also, that at the area where you have a significant amount of volume reduction, the stent is very well opposed to the vessel wall. But at 7 o'clock position, you can see that there are areas of cracks in the nodules also. And so because of this sort of malpositions and under expansion, we decided that we'll go with a 4.5 millimeter balloon. And finally, with a 4.5 millimeter balloon, we were able to achieve a good flow. The stent was well expanded, and he did well after that. Now, this would be a typical scenario wherein you would prefer a rotablation step-up burr approach, wherein you have a huge vessel, you haven't done much with an 1.5 millimeter burr or 1.75, probably you need to go with a 2 millimeter burr, and then probably you would achieve a significant amount of volume reduction in that particular area. Well, when do we decide on orbital atherectomy? As Dr. Shyam is present, when you have nodules protruding into the lumen, when you have eccentric calcification, wherein the rota may not really help us in those situations, orbital atherectomy would be a better option. And this is a patient who presented with effort angina, critical stenosis of the left main bifurcation. In these images, you could see that there is a significant calcification in the left main bifurcation. In the second image, you could see that now fluoroscopic image, you could see that calcium is extending into the circumflex. Calcium is also extending the left descending artery, and we did an OCT. That arrow points towards the ostium of the circumflex. You can see that there is a nodule of calcification which is actually protruding into the lumen at the LCX ostium, which can be very clearly made out in the 3D bifurcation mode. You can see the circumflex ostium on either sides of the circumflex ostium. You're able to see nodular protrusions over there. So because of that, we probably thought that in this particular situation, orbital atherectomy would be better. And again, you could see in the last image, the pink arrow points towards the circumflex ostium, wherein you could see a thick nodule right at the ostium of the circumflex ostium. And again, the nodule was almost 1.75 millimeter. So that was a thick nodule at the ostium of the circumflex artery. So we went ahead with orbital atherectomy of the LAD as well as the circumflex artery. And LAD we went up to 120,000 RPM, and the circumflex it was just 80,000 RPM, primarily because it was a small vessel and angulation there. So that was the reason why we decided on low RPM atherectomy with orbital in the circumflex ostium. So these are the images pre and post procedure left main bifurcation. Pre-procedure left main bifurcation, it was less than 2 millimeter square. However, after orbital atherectomy, it became 3.3 millimeter square. And at the circumflex ostium, you could see that following the orbital atherectomy, the nodule has been totally shaved off. The second image shows you that the nodule has been shaved off, and this is something interesting. You have an eccentric nodule at the left main bifurcation, eccentric calcification at the left main bifurcation at 12 o'clock, 1 o'clock position. You can see that the thickness was almost 1.6 millimeter. Following the orbital atherectomy, you could see that it's totally shaved off and it has become half the size. It's become 600 microns at there. Now that was again the 3D bifurcation. You could see that the first image shows you that prior to orbital atherectomy, this was a nodule-like. Now if you could concentrate on the second image, you can see that the nodule has been significantly shaved off with orbital atherectomy. And then we went ahead with a balloon-based strategy, that was an angiosculpt. Following that, you could see again in the OCT that there is a significant amount of crack at the 5 o'clock position. Basically, this was the area where we had a significant volume reduction with the orbital atherectomy. That was the area at 5 o'clock position. You are seeing a significant crack which was made by the angiosculpt balloon. Now we went ahead with the stenting strategy. DK crush was done, and that was the final result that we could achieve in this particular patient. So in these subset of patients wherein you could have a significant amount of nodular protrusion or an eccentric calcification, probably orbital atherectomy would fare better than a rotablator, or else if you were to prefer a rotablator, probably you will have to upsize the burr to a 2 millimeter or even a 1.75 millimeter burr. Now what is situations wherein the laser will be helpful in ablating the calcium, that's excavating the calcium. This is a patient who had a stent implant to the proximal left-hand descending artery in 2023. Long ago, he came in 2023 with effort angina in a nearby hospital. They tried to open up the lesion. The lesion was not dilated. It never looked like a calcified lesion, but then they were not able to dilate it. So he was referred to us with the balloon with the sheath in the radial artery. So we decided that probably it was a short-looking lesion, an uncrossable lesion. We were new with laser, so we thought that we would try doing a laser for this particular patient. You could see in the caudal cranial views that there is a protrusion there. It looks like a nodular protrusion on angiography. So we decided on lacing. We started off with a 0.9 millimeter laser catheter. We laced with a normal saline. We laced with contrast. In this particular image, you can see that we were lacing with the contrast also, so that we could achieve a better luminal gain. So following contrast as well as saline lacing, the lumen that we could achieve was better than what it was prior to that. We did an OCT run. These were the pre and post procedure images in the caudal view. You could see that there is a significant luminal gain in the caudal views. In the cranial views also, you can see that there is a significant luminal gain in this particular area following the lacing. And we also did an OCT run, and we made out that you could see that the luminal gain was almost 3.28 millimeter. And you can see also calcification over there. This is the OCT run. You can see that when you look at the frozen images, you can see that there were areas of nodular protrusions could be seen, as well as eruptive nodules were seen. So both type of calcification, even concentric calcification was seen. We tried opening it with an Wolverine, but we were not able to do that at 20 atmospheres, so switched over to IVL. With the help of IVL balloon at 80 pulses, we were able to open it up. Finally, we were able to stent. Those are the post-IVL images. You could see that this was a nodule over there. This was a nodule over there, and the nodule has been cracked over there. The nodule has been deformed. The nodule has been cracked over there with the help of IVL. And again, you could see in these images there are cracks there. at 1 o'clock position. So multiple cracks were made, and finally we were able to dilate it, we were able to stent it, and we were able to achieve a good result in this particular situation. These were the final images, and even the OCT images were looking good. There were no significant struts over the circumflex ostium, and we were able to achieve good result in these patients. Now, dear friends, to summarize, we have three options. We have three options: the rotablator, the orbital atherectomy, and laser. Probably we are all very well used to rotablator. Now we have these two additions in our armamentarium. Probably orbital atherectomy would be much helpful in situations wherein you have nodules as well as you have eccentric calcification, wherein you do not have a wire bias towards that eccentric calcification. And laser, it's got niche indications, probably wherein you have an undilatable or an uncrossable lesion. Thank you so much for your patient hearing.